problem with abdominal wall need to wait. And actually the same for bariatric surgery, where in France there is many procedures, so everything is blocked. So we do emergency and oncological cases.
Okay. We in India also are like not so at present denying any surgeries, though the numbers are rising up. But I think most of us who are in government sectors still have not started doing elective cases, especially except the oncology one.
So, but it seems that in 2 weeks we might restart in the public also. Let's see if the situation keep. But also now we have the Christmas time, and then due to holidays, we increase the number of beds, but decrease the number of people in the hospital. So it's kind of a mess.
Okay. So you might be having a long pending list of surgeries.
Long one. And in France, we follow Spain and Italy. After 1 or 2 weeks. So we're listening to a Spanish and Italian guy, and we do exactly the same.
That's true. So I think, yes, Amrita, I think it's 6 now.
Yes,
Amrita?
sir. Yes, sir.
Shall we?
Chintan sir, shall we start?
Yeah.
Yeah, I think we have some 80 plus.
Just, I think maybe wait for 15
yes.
seconds. I'll start recording and we can go ahead.
Sure. I think people are still joining.
Yeah. Good to go.
Okay. So a very good evening to all the participants from India, and a very good afternoon to everyone who has joined us from Europe and abroad. I am Rita Jangam. Welcome you all on behalf of Merrill Endosurgery family for this collaborative platform, which brings us the opportunity to learn from the experts nationally and internationally. So without any further delay, I would now like to introduce our moderator for today's webinar on laparoscopic management of hernia and hepatobiliary surgery and European perspective. Our moderator for today, that is Dr. Gaurav Maheshwari, is the Associate Director in Department of Surgical Gastroenterology and Minimal Access Surgery at Paras Hospital, Panchakula. His special area of interest are in the field of hepatobiliary surgeries, liver transplant, and gastroenterology. To highlight a few amongst his various achievements professionally, Sir has been a part of the VVIP delegation on healthcare with the Honorable President of India, Shri Ramnath Kovind, in 2018. He has delivered several lectures and presented papers in various international platforms. He has also various national and international publications in reputed journals with a very high impact factor. It is indeed our pleasure, sir, to have you with us today. Over to you, Gaurav, sir.
Thank you very much, Amrita, for the kind words and introduction. First of all, thank you, Merrill, as a whole, as a division, and I think we have been associated with Merrill from a long time, and it's like a big family from Deepak and Chintan. We have been doing a lot of good academic activities along with Merrill from, I think, last 3-4 years. Like we started our association in way back 2016. And post-COVID, we were thinking that how can we continue this academic phase, because it has been almost waiting for a lot of my colleagues and my friends who used to wait for a academic session from our side. I had a word with David and one of my other friends in Spain, and he introduced me to Dr. Salvador, again one of the pioneers in this field. We thought that why not have a session, because we are suffering from the autocracies of COVID, where we can attach people from maybe the other part of the country, where we can get some feedback from them how to manage things for a newcomers or a beginners or people even in my age who wants to do something new. So we thought that why not start up a session, a series of sessions rather, that where we can discuss few important areas of surgery where people are trying to do venturing, and especially David and Dr. Salvador. I'm very proud to say that in my country, a lot of new and young surgeons have started putting venturing in the laparoscopic management of hernia in form of abdomen wall reconstructions. We have a large association of AWR surgeons, and they are doing a good amount of work. And I think we had few meetings with Dr. Salvador in the past also. The only concern is when new people start venturing in, they have to be guided very properly. And even when I did my training and I ventured in laparoscopic surgery, I thought that unless I have a good mentor, I am definitely bound to make some mistakes. And I don't want this to happen to my colleagues who have started doing laparoscopic surgeries in hernias and hepatobiliary surgery. So this is one of the first series of sessions, and I think definitely I'd like to introduce both of the stalwarts in these fields. And I'm very sort of honored to have Dr. Salvador Morales from Spain. He is one of the fantastic person I've ever met in the last few days. I spoke to one of my very close friends. We were together in Korea together, and he introduced me to Dr. Salvador. No words can define it. Like, he is one of the best we can get from Europe, in especially minimally invasive surgery for both hernia as well as bariatric. So, to his accolades, I'd like to introduce Dr. Salvador first. He is a chief of innovations in minimally invasive surgery and upper GI pediatric surgery at University Hospital of Sevilla, Spain. It's such a beautiful city in Spain. He had been on a various strong position and associations, like he has been past general secretary of the European Hernia Society. He is the president of Spanish Society of Surgery, president-elect of the European Association of Endoscopic Surgery also. And the next speaker for the day will be Dr. David, again, a very good friend of mine. I think we go back long when we were presenting our few research papers together in Aurangabad. For the first time, we met David there. And since then, we have been keeping in terms and talking with each other. David is going to take care of the hepatobiliary surgery. Again, one of the strongest person in France taking care of hepatobiliary surgery, especially laparoscopic and minimally invasive surgery. As I said before, a lot of people are doing good amount of innovations in laparoscopic surgery in India also, but I think David is going to sort of take us through the journey of how to start as a beginner to get into laparoscopic hepatobiliary surgery. He is professor and head of the Department of Digestive Oncology and Metabolic Surgery and HPB surgery, hepatopancreatic biliary surgery at Institute of Montsouris, France. And I am honored so much, Dr. Salvador and Dr. David, to have you on board. And I think we continue this association, take further also, and we'll definitely keep you inviting for further such sessions so that we, as surgeons, have a lot of things to learn from you. And I always say that they put me as moderator to Merrill. I'm thankful for them, but I don't think I have energy levels to go for the moderation. I'll be definitely the one person who will be looking forward to learn a lot of things from Dr. Salvador and Dr. David. So first of all, I think I'll hand over to Dr. Salvador. Thank you very much for joining us. And definitely we'll be looking forward for any sort of questions, any queries. We'll be having questions in the chat box. You can directly pass on the questions to the Zoom chat box also. And at the end of the session, after Dr. Salvador finishes, definitely he will be kind enough to answer a few of them. Thank you, Dr. Salvador.
Thank you, Dr. Gaurat. Thank you, Mary, for the kind invitation. It's a pleasure to be with my Indian friends here today. and of course, and as the moderator mentioned, I think it's important to know exactly where we are today in ventral hernia repair by laparoscopy, and to know a little bit the way we perform and how we end up having this in mind to go ahead with laparoscopic abdominal wall reconstruction. I think this has been a shift in paradigm in hernia surgery in the last, let's say, 4 or 5 years. And the trend today is to use minimal invasive surgery, and the trend is to do abdominal wall reconstruction. We all know that when we decide to go to repair a ventral hernia, we have basically two tools, an open approach and a minimal invasive approach. And the success of any technique that we decide to perform is to perform a tailored approach, because not all the cases are going to be suitable for a minimal invasive repair. So I think you always have to think that try to consider minimal invasive as an alternative, but try not to force the situation and try to do it open if there is an indication for an open approach. But if we have a hernia in which you can either perform an open approach or a laparoscopic approach, we have to decide what to do. And there is so many factors that lead you to understand what is going to be better for the patient. This factor will be the complication rate when you compare the two techniques, pain after surgery, the rate of recurrence in short, medium, and long term, hospital stay, return to normal activity, the quality of life of the patient, and the cost. And in 2018, I did a systematic review of the literature, and I came up with this chart in which you see the difference, being green, in which of the different areas it will be superior, the open approach to the standard laparoscopic approach. And you see that at that time, only the bowel injury was superior in laparoscopy, so it was better to perform open approach in that sense. And the direct cost, because of the cost or the extra cost of the intraperitoneal mesh and the fixation device, were in favor of open approach. In terms of pain, recurrence, and return to normal activity, based on the literature, there was no difference between the two techniques, but it was all the new literature coming at that time was in favor of laparoscopy, even there was no difference. But the main difference between the open and laparoscopic approach for conventional midline incisional hernia or ventral hernia was that the rate of wound infection was close to zero with the laparoscopic approach. And therefore, since we trust the surgery and there was less possibility of infection, the hospital stay based on prospective randomized trial and large register was less with laparoscopic approach. So this was telling you that laparoscopic approach in 2018, based on everything that was published in the literature, was in favor of laparoscopy. And this is the vision that I have of what had happened in the last year. And you see that there was a very interest due to this result to laparoscopic approach, but suddenly, for some reasons, the interest of the surgeons worldwide of using laparoscopy to repair a ventral hernia was less, and it seems that today is increasing. The reason why there was this area in which surgeons start abandon laparoscopic ventral hernia repair and moving into open ventral hernia repair was because the concept associated in around year 2000 to the concept of placing a mesh intraoperative. They will place in a mesh following this technique of lap IPON. And the problems is that if we have to re-laparoscope a patient, we saw strong adhesions to the meshes, to the edges, and also to the tacker that we place in previous surgery to repair the hernia. Also, there was a high percentage of shrinkage of the mesh that was in relation to some recurrence and some discomfort of the abdominal wall. And also, and the most important, is there was this bulging after the surgery, in which surgery was no, there was no need to repair the hernia, but you can see how the mesh after a year moved into the sac, and even there was no possibility of incarceration. There was a complaint of the patient telling us that there was a bulging. So, but today, the good thing and the reason why we're moving into the interest again to the laparoscopic ventral hernia repair is because we have changed the concept and we have moved from laparoscopic ventral hernia repair to minimal invasive abdominal wall reconstruction. Is abdominal wall reconstruction because we are not going to cover a hole, and it's minimal invasive because it's not only laparoscopy, because it's also endoscopic approach through the retromuscular space. So we have moved from this lap IPOM to minimal abdominal wall reconstruction, and you can see an abdomen that re-laparoscope with a perfect reconstruction of the abdominal wall. And if you perform a CT scan of the patient 1 year after the surgery, you see how the rectum muscle are in the middle. And even if you consider this is the normal CT scan, this is a CT scan after a patient, after performing a laparoscopic minimal invasive abdominal wall reconstruction. So we have moved from what we have this lap IPON in 1993 to what we had last year, this minimal invasive abdominal wall reconstruction. And I will tell you how this journey have been in the last year. The main concern of surgeons who were doing laparoscopic IPON at the beginning was the bulging. And you can see the CT scan as I mentioned. And that's the reason why in 2007, Elie Lala published this paper with 400 cases in which they start closing the defect. This was called at that moment IPON Plus. It was an IPON, but the different and the plus came from the concept of closing the defect. And the rationality behind this is because the idea was to avoid this bulging, this pseudo-recurrent bulging, to reinforce the abdominal wall and increase functionality, and also to decrease the dead space and decrease seroma. Many surgeons around the world start closing the defect. The way it was described at the beginning was just transfascial suture, just closing them. At the beginning, I can tell you that I was in that part of the face-to-face in the meeting being against this way of closing because of the tension, and I didn't like much this way of closing. For that reason, and since I really believe in the concept of doing something else, we developed our technique of closing the defect. And what we did was to follow the same concept that we do in open surgery. What we do is start with the double loop. We maintain the thread outside, and little by little, we were doing a closing of the linea alba, and at the end, we decrease the pneumoperitoneum, pull up the two thread, tie them in the subcutaneous tissue, and be able to make a new middle line for the patient. Today, we can see that this theoretical advantage of IPON Plus over IPON have been demonstrated. And we have a paper that's saying that just closing the defect, the patient was going to have less recurrence, less bulging, less seroma, and was going to have more satisfaction. And in fact, last year in Annals of Surgery was published a multi-center blinded randomized clinical trial in which it was demonstrated that the quality of life of the patient after an IPON Plus, which is placing a mesh intra-abdominal and closing the defect, was superior to the traditional lap IPON. So we can say that IPON Plus, after 6 years of this paper, after more than 10 years of this paper, demonstrate that it's superior to just placing the mesh and bridging the defect. The question that was raised in our group when we start closing the defect using this running suture was which was going to be the limit to close the defect. We start closing all the defect, even defect more than 10 centimeter width. But in a few days, in a few months, we realized that we were able to close defect like this one with 14 centimeter width. After 1 month, they were okay, but after 1 year, then we have the same effect of bulging. So there was no sense, even that we were able to close those defects, there was no sense to keep closing this defect. And in fact, in a meta-analysis published by the group of Nail Smart, they came out with the same conclusion. Defect more than 10 centimeter shouldn't go in closing the defect and placing a mesh, and surgeons should do something else, like a component separation. So that was the first step in our protocol. Less than 10 centimeter width, close the defect. More than 10, don't close the defect because you are going to have a recurrence or a bulging. So in those cases, you have to use a component separation. Regarding component separation, there is two ways of doing it. Doing an endoscopic approach to open and transect the oblique muscle, or doing the posterior component separation, the TAR. We were in favor of doing this posterior component separation over this endoscopic posterior component separation. You know that the endoscopic and posterior component separation was done in the lateral side, and then you can continue either with an open approach or you can place the mesh intra-abdominal and close the defect. So moving into doing the the posterior component separation, and then allowing to close the defect by laparoscopy. While in the posterior component separation was a totally different technique. And the advantage was that you will preserve the vascular supply, you will preserve the nerve supply of the muscle, and the good advantage is you can place a large polypropylene mesh in the retromuscular space. We reviewed the literature and we published this paper last year in which we compare the anterior component separation with the laparoscopic posterior component separation. And you can see that there was more advantage in terms of complication of recurrence of using this laparoscopic posterior component separation. So now I can say that in more than 10 centimeters, we perform laparoscopic component separation TAR. The question still there. What about those with less than 10 centimeters? Is going to be a long-lasting reconstruction? Is going to be a more painful technique since you are adding tension in the midline?
Sorry, Dr. Salvador, by mistake, got on mute. Please unmute.
You hear me now?
Yeah.
Okay. So we observe what happened with this defect around less than 10 centimeters. So the first thing is we stratify our patient in from 10 to 5, and we observe some cases in which we have the same problem with more than 10. And in all cases, we observe that after 30 months after surgery, the midline get together, and in those cases of median size of around 6 centimeters, we move into 2 centimeters. And after a year, start opening a little bit to 4 centimeters. It didn't open to the previous side, but it start opening a little bit. We observed that, and we observed that there was a difference between those cases less than 10 centimeters or 5 centimeters and those cases from 5 to 10. So what we did is to analyze which factor influence on the recurrence rate and the bulging rate. And with 3 years of follow-up, we have a 6% of recurrence and a 20% of bulging in our patient that we start closing the defect. And we observed that pulmonary obstructive syndrome was one of the factors that influenced the presence of recurrence and bulging. And in terms of size, from 5 to 9 was the more important factor in terms of having a recurrence of a bulging. So for that reason, then the question was, as it was published in the literature in that meta-analysis of Nail Smart, less than 10 centimeters, you can go ahead and just close the defect. From 5 to 10, there was going to be an important group of patients in which the technique is going to fail. And the reason is easy to understand, because if you join together the two areas of the defect, the two fibrous tissue of the defect, there is no healing process here. And after a year, after performing, after doing normal life, they are going to open because they are not going to heal together. And in fact, we run a paper, we run a study that it was published that if you produce an inflammatory process of the peritoneum, in a control group of placing a mesh against peritoneum, there was going to be no fibroblasts and new vessels. While if you create this inflammatory process of the peritoneum with cautery, you are going to increase the ingrowth and increase the number of fibroblasts and new vessels. For that reason, we decided that in those cases from 5 to 10, we had to do something else. And that's the reason why we developed the LIDA technique. The LIDA technique is that basically instead of joining the two edges of the defect, we open the fascia of the muscle, we flip them together in the linea alba, we join them together. This means that it's going to be no tension, and that means that there was going to be a better process of healing in the midline and a better ingrowth of the mesh, because this muscle exposed is going to integrate the muscle in the
open, so you can feel some like.
So this is the way we do the technique. Pneumoperitoneal in the left upper quadrant, place 3 trocar. We identify the defect. This is a recurrent umbilical hernia with several defects in the linea alba. we do the desciolysis, then we remove the round ligament of the patient. Basically, we identify the muscle and we start opening the rectum muscle to expose the muscle and having the chance to have a better ingrowth of the mesh. We do it in one side and then we move into the other side. And then we identify the area that we were going to be ready to close. And the most important thing that we just not closing the defect, we were doing the repair of the old linea alba in a ventral hernia, doing the repair of the rectal diastasis, and in case of incisional hernia, including the whole incision. Once we were ready to have this area of deficiency of the midline, what we were going to do is to mimic what we will do in a standard incisional hernia. So this closure of the midline, you can do it either with a barbed suture or with a double loop. You can see here how we maintain the loop outside. Then while we maintain the loop outside, we cross through the double loop so it will lock by itself when you pull at the end. And we start doing a running suture and little by little introducing the suture inside the abdomen to be able to perform a proper closure of the midline. So you can see that you have to be a well-organized surgeon, going little by little, introducing the loop. You can see here, or the smooth movement is a technique that doesn't take long as you are doing step by step. And at the end, once we have almost ready the closure of the linea alba, what we do is we perform a small incision on the skin, and with an endoloop, we bring outside both sides of the thread. Same skin incision, but different fascia incision. And when you pull with the two of them, what you do is you decrease the pneumoperitoneum. And once you decrease the pneumoperitoneum, you pull on the two thread and you close the linea alba. And then the next step will be to reinforce this area with a mesh. So you see here all the thread and how then we decrease the pneumoperitoneum. You see the image down here, and we start pulling of the two of them and joining together in the linea alba, the both sides of the fascia, that you know that they're going to heal together because tissue that is going to heal is ready to heal together. So then later, what you're going to do is to reinforce this area, and the overlap originally was 5 centimeters over the defect, but now today we know that we have to go only 2 centimeters overlapping the fascia. That means 2 centimeters in this direction, 2 centimeters in this direction, and then reinforce the area using a mesh. So we analyze a prospective analysis of the LIDA versus simple closure. Simple closure is the blue line, and you can see the opening of the two rectum muscle after a year, while with the LIDA technique maintain the same size after a year. And the reason is easy. It is a long-lasting reconstruction that is going to heal. And since it's going to heal, they're not going to open. And at the same time, by opening the fascia here, you're going to decrease tension. And that's the reason why it's going to be a long-lasting reconstruction. And by having no tension, you are going to have less pain. And we compare the result of just closing the defect with the LIDA technique, and you can see that we maintain a good VAS rate for the patient day 1 and day 7. And it was less pain than just closing the defect because you decrease the tension. So these are the advantages of this LIDA technique: healing process, no tension, long-lasting reconstruction, and less pain. And this was indicated for those cases from 5 to 10. But then what we decide to do the same, but to the edge of the rectum muscle, do the same to those cases with less than 5 centimeters. And less than 5 centimeters today, we do the same, and we include all the rectal diastasis and all the incision of the patient. And the good thing is that in the future, we can move in using absorbable meshes to repair that. I cannot advise to do that today, but this means that since there is only the need of a support because the heal is a healing process, maybe we can see the future like totally different thanks to this new technique of minimal invasive abdominal wall reconstruction. So this has been our own journey through the time of lap IPON to minimal abdominal wall reconstruction. The good thing of this LIDA technique is that since we have a new midline without tension, we can even avoid these tuckers that were creating sand adhesions. We know that we were using tuckers, and you saw this the study of Holinsky, because the strength of suture and protac were higher than absorbable tucker. But the good thing of absorbable tucker is we have less adhesions. So the reason why we're using absorbable tucker today and using this LIDA technique is because we can avoid these permanent tucker that are related to adhesions based on what we show in many studies. So since we are using the mesh just to support the midline, while the midline heal, thanks to this opening and this inflammatory process, we can afford to use absorbable tucker to give, because we only want the strength during the first 6 months while the midline heal. So the LIDA technique avoid the use of permanent tucker and offer the possibility of avoiding this bulging. We still have the criticism of using an intra-abdominal mesh, and for some reason, surgeons have performed this LIDA, lap supply, in which they do like a tap technique. They expose the muscle, do the crossover, including the hernia and including the diastasis. Later on, we go to the other side of the muscle. And after that, what we will do is close and join together the midline. And at the end, what you will do is to close the midline, and at the end, close the gap and do like a tap. In a way, this technique, the lap supply, it will be like a tap. And to perform like a tap will be the Milos, described by Wolfgang Reinpel, or the E-tap technique. So this technique will work directly in the retromuscular space. The question will be today, if we should go for these techniques or we should go for this technique. What is clear is that we have to close the defect. Then we have to decide to go for the LIDA with the intraperitoneal mesh or go to a retromuscular placement of the mesh, either like a tap, like will be the lap supply, or like a tap, that it will be the E-tap and the Milos. This is what we have today. This group of technique and this group of technique. What I think personally is that the LIDA technique, even that you place an intra-abdominal mesh, and all companies today have an excellent mesh, these meshes could be placed and fixed with absorbable fixation device. It is more reproducible and it fits for almost all indication. While in my opinion, this retromuscular placement of the mesh, this endoscopic or laparoscopic placement of the mesh in the retromuscular space, it is true that you avoid the mesh intra-abdominal, but these techniques are more complex and are more difficulties to perform the crossover, especially if you have an incisional hernia. And this is the reason why I'm only performing this technique in those cases in which you have a ventral hernia, in which you are not going to find the fibrous tissue in the linea alba. And since the LIDA is more reproducible, I can say today that I still receive WhatsApp and email from different parts of the world, or people performing this technique described by our group. So today, this is what we have. If you want to mesh intra-abdominally, or if you don't mind, use the E-LIDA or the LIDA and endoscopic anterior component separation. And if you don't want to mesh, use the posterior component separation for those more than 10, and use the laparoscopic rivet stop at subplay, either by a tap, transabdominal, or by TEP, ETEP, or Milos. And this is what I personally do. Incisional hernia, since I have difficulty to do the crossover, I do the E-lira and lira for those less than 10, and the TAR because it's superior, in my opinion, to endoscopic component separation. If I have a primary ventral hernia, those less than 5, I do the lap supplay because I can do the crossover in the proper way. And for those cases from 5 to 10, I do the lira and the TAR for those cases more than 10. And in case you have a problem on the skin, I combine my minimal invasive approach, and at the end of the procedure, I remove the scar, because that way, these hybrid procedures, you maintain the advantage of the minimal invasive approach. So in my opinion today, the new trend and the advance of this technique is that we move from the lap ventral hernia repair, the classic lap IPOM, to minimal invasive abdominal wall reconstruction. And the trends of surgeons worldwide today, I will say, that is to follow this concept of going minimal invasive and performing an abdominal wall reconstruction. And consider that a hernia, this is a primary hernia, is not just a hernia. And you don't have to work on this small hernia, that you have to reconstruct the linea alba and work on this diastasis better than just a hernia. And if you have a patient like this, what you have to do is to consider that if you have a hernia in the middle of this rectal diastasis, you have to repair the whole linea alba to success. So this is what we want. We want in the future, if we will repair a patient by minimal invasive, to have the two rectal muscles joining the linea alba and be able to do a proper abdominal wall reconstruction. Some boys were saying that for this you need a robot, and I will send another message. And just consider that to perform a proper minimal abdominal wall reconstruction, you can do it either by laparoscopy or endoscopic, depending on the technique you choose. But if you have a robot, you're going to have more comfortable, but don't be afraid of performing this technique by laparoscopy, because you can do it. Thank you very much.
Dr. Gaurav, you can unmute first. Gaurav, so please unmute.
Yeah. Can you hear me? Yeah. Thank you, Dr. Salvador. Fantastic presentation. Really, when I was going through your paper on Lyra, I was a bit confused. But after seeing these fantastic videos, I think makes a lot of life simpler for us who really want to go into this technique also.
Thank you.
I think we have, during the presentation, understood few things, but I have a bit of questions from my side also, and few chats and questions from the listeners. So one thing is, Dr. Salvador, first thing is, as a beginner, suppose if I want to venture into Lyra after doing a good number of IPOMs, so what are the technical tips you want to share with the beginners where we can have some amount of a difficulty, and which are the major areas of concern where, as a surgeon, as a technical points where we can get stuck?
Yeah, I think it is important, several things. First, proper indication. I think this is very important. If you are going to perform a case in which the patient have a previous retromuscular mesh, you are going to start with difficulties. So the best way to do it is to start with a primary hernia, or either with a recurrent of an umbilical hernia without previous mesh. This is very important. Second, don't select a patient with a large incision or a patient with an important hernia with an important diastasis, because you have to do a long suture. And it's better to start with a small suture so you can manage yourself in this way. The third thing, I can tell you that some people doing this technique worldwide today, they're using the way I show you with the double loop or there are some people using it with the barber suture. Just choose whatever you feel more comfortable. But for some reason, it's better not to have too much tension when you close it. So it's better to start doing those cases with less than 5 centimeter width. So select your case to make it life easier at the beginning. Once you get skillful enough to go in larger defect, then move. But don't start with large hernias because you're going to fail.
Okay. Yeah, fair enough. One more thing, Dr. Salvador, like we have been taught from the beginning that the the overlap of the mesh, it has to be a huge one. Like even for a defect of something like 5 centimeter, we have been taught that you have to have a cover of something like 7 to 10 centimeter all around the circumference of the hernia. Once with you have this Lira technique, you said that 2 centimeter of cover is good enough. So have you, in your experience, noticed any time migration of the mesh or shrinkage of the mesh in post-operative follow-ups?
Yeah. When I start closing the defect with a running suture, there was so many people asking me, well, officially following the guidelines, you have to overlap the mesh, the defect 5 centimeter in different direction. So if you close the defect, then it becomes zero. So becoming zero means that you have to go just 5 and 5 in one side, which is not true. And at that time, we were recommending to maintain the original measure to use the mesh. That was the advice. Since we start doing the Lira technique, I open the fascia.
Okay.
So what I do is an overlap the opening of the fascia 2 centimeter. I don't overlap the defect. I overlap the opening of the fascia. That is a totally different concept. So what I do is I'm going to place my tackers over the fascia to guarantee a proper strength of the mesh. And then just 2 centimeter with minimal integration, but the whole mesh is going to be in contact with the muscle, and you're going to have a better ingrowth. So it's not overlapping the defect, it's overlapping the opening of the fascia that you create. And you go 2 centimeter overlap in that direction.
Okay, fine, fair enough, sir. One more person has asked me, once you close the fascia with the loop suture or barb sutures, the space between the skin and the subcutaneous space is just left behind. So do you do something for that, or the incidence of seroma is more in Lira as compared to the other procedures?
Well, we are going to have the data, but I have the data from closing the defect.
Okay.
And I can tell you that because we follow, as I mentioned, we follow all our patients with CT scan, and we observed there was seroma. The question is not, and we published that in 2012, is not if you have seroma or not. If you have a symptomatic seroma, but producing any complaint or any problem to the patient, I think that the dead space still going to be less, but any dead space means seroma, means liquid there, but it will be liquid there that is not going to be in contact with the skin. So the advantage is you are not going to contaminate that. So we demonstrate in our series that we didn't decrease seroma, but we decreased the number of seroma that create a problem. And that's the most important thing.
Yeah, that's true. That's true. One more thing, what somebody has asked is, have you done this Lira technique in patients who have got obstructed or strangulated hernias?
Well, I haven't done it in any cases in emergencies, but I will do the same. I will check the bowel and consider. And I had one cases before to start doing the Lira, and what I did is just close the defect with no mesh and with no opening of the fascia, because I just closed the defect to avoid an acute incarceration. I have the quality of the bowel was fine, but it was some contamination. So I just close it and I tell the patient, I'm going to operate you in 3 months and reconstruct the linea alba. So I use the closing of the defect without opening the fascia just to avoid another strangulation.
Fair enough. What I understand, Dr. Salvador, is like what one of my seniors in India used to say, Like a repair of a hernia is like a marriage. Like if you have tension in marriage, it's going to fail. So the whole concept of your hernia was like you have to have a tension-free repair by doing lira or other techniques. But in case if you have tension during your muscle repair, it's going to definitely fail sometime soon.
That's right.
There is something what people have tried in, I think in Spain also they've done. There's something called a subcutaneous only laparoscopic repair in which they don't enter the peritoneum, especially for patients who have divarication of recti or small umbilical hernias. Get into subcutaneous planes and do a onlay repair and put a normal non-absorbable mesh. Uh, did you have tried sometime something like that anytime?
Well, the thing is like, I have to tell you that I have a lot of patients, especially postpartum female with diastasis and primary hernias of the linea alba. And in my opinion, the problem that we have is why the patient have concern when they come to you. Usually they come because they have the diastasis and because they have an excess of the skin. So I have to be honest that in those patients, I go into the OR and I do an open repair with the plastic surgeons. And I do a dermalipectomy and then an open repair because the plastic surgeon opened the abdomen, expose all the fascia, I reconstruct the linea alba with a mesh, and then he closed performing a dermalipectomy. So that's the reason why I don't use those cases. It's totally different of a patient, an obese male patient with a hernia with a diastasis. In those cases, I do a LIDA technique or a suplay to repair. So in my hands, in my cases, I don't find any cases for this subcutaneous approach because a good indication is female postpartum, and those female postpartum, in my opinion, is a perfect indication to do a combined surgeon with the plastic surgeons.
I think that makes sense. There's one question from Dr. Mohanty. They've asked like how many patients, in case you had any, had mesh infections post-operatively.
Well, out of my experience that started in 1998, I think, with lap ipon and LIDA and all this technique, that is maybe more than 1,000. As I remember, I remember just two cases of infection.
Okay.
One was an obese patient that for some reason another surgeon punctured the seroma and there was a contamination and infection of the mesh. So it was not because of the technique, it's because someone punctured the seroma. And the second case is because a new meshes that came to the market that now is out of the market for these complications.
Okay. Okay. And the last, I think I have a lot of other questions which I'm not going to, I'll just pass it on to you, Dr. Salvador. One thing is, do you have any specific approaches for subcostal hernias?
Yeah, subcostal hernia. What I do is I close the defect and I place the mesh. The only thing that which is very important is to consider what you're going to do for the upper part, the cranial part, or how are you going to fix the mesh in that area.
Yeah.
So if you're too close to the costal margin, I would recommend not to use any fixation device, and what you should use is transfascial suture through the intercostal space. So my recommendation in subcostal and subxiphoid hernia is that you have to use transfascial suture through the last intercostal space.
Okay. And any same goes for the pelvic hernias, like deep in the pelvis?
Though deep in the pelvis, I do a suprapubic approach. I do a bilateral flap like a TAPP and expose the Cooper and the pubis bone, expose all the anatomy, nerve, the most important vessels down there. And then what I do, I fix the mesh to the pubis and Cooper. In those cases are the cases in which I would recommend to use permanent tacker, because to go into the bones, it's better to use this permanent tacker that the deployment system are stronger and it fits better in this area.
Okay, fine. This is again one of my favorites. Like Mrs. Savitri, Dr. Savitri is asking, how many of your patients post Lira have a significant amount of pain in the post-operative period, like on a scale of 10? Do I have a good amount of pain?
Well, you've seen today that the rate of pain that we have in our series after the LIDA technique, I think day one was around 4 in the scale from 0 to 10, and it was 1 in day 7.
Okay.
So and it was like 4, and with the closing of the defect, the bus rate with the closing the defect was around 6. So we decreased the rate. Is still painful, but we decreased the rate from moving from closing the defect to LIDA technique.
Because in our set of patients, at least in my department, what we have started is one thing we noticed that when we used to use non-absorbable tacks, the more number of tacks, it used to create a lot of amount of pain. The pain scale used to go up almost up to 7 or 8 with significant amount of ILS. So
yeah, we published 2 weeks ago in Minerva Chirurgy, which is an Italian journal, a paper that is now online, in which we demonstrate that by reducing 1/3 the number of tackers of you use, you get the same recurrence rate but less pain.
Okay, great. And last, Dr. Chakravarti is asking, is any specific amount of criteria for the mesh you decide for a set of patient, or you are, as a blanket, you take one mesh for your majority of cases?
I have to tell you that depending on the availability of the mesh in the hospital, I know what I don't want to use.
Okay.
I have clear mind. I don't want what I don't want to use. But if they give me a mesh from some companies, let's say including Merrill that they're here today, I feel comfortable with them. What I wouldn't use is some macroporous mesh. But those mesh prepared, we have in the market excellent mesh today to be used.
Okay. So I think the rest of the questions, I think we can, in case we have at the end of the meeting after David finishes, we can come back to you, Dr. Salvador. I'll take some time to introduce Dr. David. I already had. David is again going to speak on hepatobiliary surgery, and I think one of the interested topics which we have seen in the last few years in our country also, that a lot of people are venturing into laparoscopic HPB surgery. And as Dr. Salvador said, that anything which has to be done in a confident way with minimizing complications. So, Dr. David, over to you. And I think we can start with the presentation. Thank you, Dr. Salvador. I'll get back to you at the end of the presentation. Thank you very much for such a nice videos and presentation.
Has been a pleasure.
Yes, David, sir. Thank you.
Thank you. First of all, I would like to thank you, Gaurav, and all the organizing team for this very kind invitation. It's a pleasure and an honor for me to present something about liver resection by lap. Second point, I would like to congratulate Salvador for his fantastic presentation. I understand everything. I had many questions. It's a fantastic presentation and overview of this very, very important topic. So the third point is I need to start. So the question is how to develop laparoscopic liver resection. So actually, innovation in surgery, and Salvador just showed us that we decrease significantly the size of the incision, and we modify the size of incision and the position of the incision just to decrease the complications, the pain, and to increase and improve the recovery. So actually, if you check about innovation in surgery, you can see that according to the different kind of procedure, there is a time here by years, and a proportion of surgeons who accepts this new approach. And you see that for cholecystectomy, which is a quite simple procedure, it needs almost 4 years to obtain more than 75% of all surgeons to start and to achieve laparoscopic cholecystectomy. It's very interesting because with a fundoplication, it's a little bit longer. For hysterectomy, a little bit longer, but actually there is no information about liver surgery, no information about pancreatic surgery. And there is an obvious delay between the publication of the first paper about laparoscopic liver resection and a significant increase of number of papers. This is a very interesting nationwide study in France published by a national group showing different things. The first thing is between 2007 and 2012, there is less than 10% of all liver resection performed in France are done by lab. And the second message is there is no evolution. So it means that it's always less than 10%. Actually, it's very interesting to show that here at the beginning of the new technique, and Salvador is a leader, is a beginner in this new approach. There is innovators. So people who create a new approach, a new technique. And then there is early adopters. So just after the leaders at the beginning, and the problem is the increase of diffusion of this technique will start when more than 15% of all surgeons will adopt this new approach. So actually, it means that for liver resection in France, we are behind, we are below the tipping point, and we need to overpass this tipping point to increase the diffusion of this technique. So why do we have an obvious delay of this new technique? Because it's not very difficult to understand. First, it's completely different. So it means that we change the approach. So it means that we used to use a large incision, sometimes with a Mercedes symbol here, and we reduce the size, we reduce position of the incision. And for right hepatectomy, the large incision is a suprapubic incision. So our view is totally different. It means that we don't see anymore the liver from above, but we see the liver from below. So the segment 1 from an open approach is very, very difficult to find, but it's very easy to find when you start by lap. And it means that even anatomy does not change with the laparoscopic approach, but your view is different. So you need to be cautious and you need to take into consideration all this modification. So this is totally different. And if you show to a traditional, conventional HPB surgeon this position or this position or this position, nobody can understand that this is a liver position patient for a posterior segment. But actually, we use this position patient to treat tumor located in the posterior segment. Second point, it's a difficult procedure. It means that it needs a significant learning curve. Here, this is the beginning of this is early experience, and this is advanced experience. This is conversion to open, this complication. And you see that for left lateral sectionectomy, which is a removal of segment 2 and segment 3, this is a very easy case. It means that you will improve the rate of conversion over time. But for right hepatectomy, it needs a lot of time. Of course, there is some tips and tricks just to reduce the learning curve. It used to consider hand-assisted, but it has been totally abandoned because it's difficult to make surgery with only one hand. And this is a hybrid technique with only mobilization of the liver by lap and to do a midline incision just to cut the parenchyma. And I think that today we're discussing about the pure laparoscopic liver resection. Then it's potentially risky because the liver is full of blood, full of vessels. This is the hepatic veins, this is portal veins, and even at the end of the procedure, it can occur some major bleeding. And interestingly, this is a national report, national clinical database from Japan. And we know that Japanese surgeons are very, very long, very strict, excellent surgeon. And you can see here, it's only including patients with major hepatectomy that when they match population of major hepatectomy in the country, there is 12% of major bleeding more than 2 liters in the open group and in the lab group. And the problem is, by lab, you have only this. So a bipolar forceps, some cotton, some vascular clamp, and a stitch. So maybe it can be very dangerous. And finally, this paper showed that in centers which perform more than 100 liver resection a year, so this is academic, this is the largest centers, they don't do laparoscopic approach. And on the contrary, centers with less than 5 liver resection a year are doing much more laparoscopic approach. The problem is young surgeons are trained in academics centers where there is no lab. So we need to change. But is it necessary to do lab? Actually, the answer is yes. And I will explain why. Here, this is a morbidity of after liver resection. There is 5 large classes or 6 large classes of complications. This is liver failure, bleeding, bile leakage, pulmonary complication, other complication related to the liver, and extrahepatic complication. So actually, here, this is overall, this is incidence of all these complications, and here, this is the weight of each complication on postoperative death. So, for example, it means that liver failure is a non-frequent complication because it's only 5% of all liver resection. However, it means that 1 death of 5 will die of liver failure. So it's a very, very severe complication. And actually, when you focus on liver failure, there is some literature showing that there is a benefit of laparoscopic approach, since you don't cut the vessel in a subcutaneous vessel, you decrease the ascites, the postoperative ascites after resection, and there is a tendency toward reducing the liver failure postoperatively. For bleeding, actually, the lab trying to decrease the blood loss, because we change the technique, we discuss with anesthesiologists, and we are moving towards zero transfusion because we have many, many tips and tricks to decrease the blood loss. With the pneumoperitoneum, we are able to see better the vein. With a low pressure, low central pressure, we control this bleeding. We can move some ventilation and airway pressure with the anesthesiologist, and we can have some Pringle maneuvers of vascular clamping and so on. So we're trying to decrease, we decrease the intraoperative blood loss, and we decrease the intraoperative transfusion. For bile leakage, this is not a miracle. So it means that the incidence of bile leakage is around 8%, and unfortunately, there is no benefit from lab compared to open. So we don't modify anything. With pulmonary complications, this is very, very, very frequent complication since it occurs almost 0.5% of liver resection. And in a multivariate analysis about risk factor for pulmonary complication, the risk factor are transfusion, nasogastric tube, operative time more than 6 hours, and interestingly, this, a large subcostal incision. And actually, this is a major risk of pulmonary complication because you cut everything, you cut muscle for breathing and so on. So this is a major point. And actually, we published multi-center studies, 2 centers comparing pulmonary complication between lab and open. Of course, we compare at the beginning apples and pears, but after matching, actually there's a huge benefit of lab compared to open on all complications except pulmonary embolism. So it means that laparoscopy increase and the postoperative recovery and decrease complication and length of stay. And there is a first randomized controlled trial showing that there is a benefit for the patient. So for colorectal liver metastasis, there is no, so the survival is exactly the same. And with a reduction of adhesion, you can start another time for recurrence because around 70% of all patients will recur, and actually you can start a repeat, you can make a redo, you can go one more time, and actually you can go 2, 3, 4, 10 times sometimes. So how can we improve this liver surgery? I think that we need to standardize the technique. So it means that we need to have correct standardization of dissection or hilum. You need to use exactly the same clips. You need to use the same tips and tricks. You can use clips, you can use bipolar, and you need to standardize your technique. Second point is you need to train with intrahepatic ultrasound, because it's mandatory for liver resection to show where are the veins and or are the tumors. So it means that you need to check where are the veins for segment 8, for example, for a right hepatectomy. You need to follow the vein and to adapt your surgical margin to the location of the tumor and so on. And for the parenchymal transection, there is many techniques. You can use a QSA, you can use a bipolar, you can use a Thunderbit or energy device just to control and to cut this small branch. You can use clips, you can use bipolar, you can use many things. But actually, when you have standardized the technique of parenchymal transection, you will reduce the risk of major bleeding. Second point is to progress stepwise. It means that actually we have published a classification of technical difficulty about liver resection. It has been published 2 years ago in Annals of Surgery, and we select all procedure and we make a classification according to the operative time, to blood loss, and the conversion to open. And actually there is 3 groups. The first group is easiest cases. So it means that resection, atypical resection in a segment 5, in segment 2, and segment 3, or in the posterior segments. And left lateral sectionectomy belong to the first group. The second group is more technically demanding. It means that a left hepatectomy is not an easy case. So it means for segment 5, for example, it's an anatomical resection. It needs to follow the pedicule and to follow the vein. So actually it's a second step, it's the intermediate step. And the last step is the expert step, is a posterior segmentectomy. It means segment 6 and 7, so it's a very difficult situation, and a right hepatectomy by lap or a central hepatectomy and so on. And interestingly, there is a stepwise progression of complication. It means that segment group 1 patient don't have many complications, and the severe complication and all complication increase with the grade. So it means that you need to start by easiest case. It means logical, but sometimes I receive some call from my friends saying that I'll start with the right hepatectomy by lap, and I say it's not a good news because it's dangerous. You can have some major trouble. So you need to start stepwise, beginning with grade A and finishing with grade 3. Then we need to find a new technique to make simulation. It does not exist yet. Even in India, in France, nowhere, it does not exist. But we need to create a new software to make adequate and accurate simulation, because it does not exist yet. And there is some cadaveric simulators with a pulsatile injection of not blood but water, red water, just to simulate the parenchyma. So it means that there is maybe new tools in the future just to train, and maybe in few time, but I'm not sure it will be so late, because there is many startups who are developing this enhanced reality and this virtual reality, and maybe we will be able to train young surgeons with this kind of tool. And enhanced reality is not like that right now. So it means that we are not able to do some safe procedure with enhanced reality. But actually, you can use some tips and tricks like ICG, for example. ICG, you inject ICG 2 days before the liver resection, and you can use a specific camera and you see the better the tumor. So of course it's a subcapsular tumor here, but intraoperatively, when you are cutting the parenchyma, you can adapt the surgical margin if there is some green on the screen. So this is easiest enhanced reality, but it can improve the quality of the surgery. So just to conclude, don't forget that this surgery is safe, but only if surgeons are liver surgeons, so you need to be trained in liver surgery, laparoscopic surgeons, so training with abdominal wall laparoscopy or colorectal by lap is a good tips just to improve your skills in lap. You need to be able to use ultrasound, and you need to start with the easiest case. Thank you very much.
Thank you, David. Thank you for fantastic presentation and video.
Thank you.
It has been so nice to see such a good amount of work you guys are doing there. And as a HPB surgeon, I think hepatopancreatic surgeon, a lot of my colleagues who are going through the session right now will be so happy and amazed to see these type of work being done. Just to start up, first of all, again, congratulations to your whole team. And we have few things, like as a beginner, you have been like telling that you have to select a good case. So which will be, according to you, David, will be the best case to start up for a laparoscopic liver surgery?
So I think that at the beginning, the best case is a atypical resection in an anterior segment. So a small resection on segment 3, a small resection out of segment 4B is a better indication. But I think that it needs time. So just explain to the anesthesiologist that he should not fill in fluid. So just keep the patient dry. Do not inject fluid. And this is the best advice you can talk with your anesthesiologist. And this is a very easiest tips and tricks, but you can use a bladder tube. You see, a bladder tube, it's very simple things. And you cut the bladder tube after 18 centimeters, 18 centimeters from the tips, okay? And this is French 18. So it's very easy, French 18 centimeters. And you put it in the abdomen, you just encircle the pedicle, you open the small omentum, the pars flaccida of the and you just put the bladder tube just behind, and in the hole of the bladder tube you put the grasp and you tract. And this is a very, very, very easy and very cheap, not expensive tips just to control the bleeding, even from easiest case.
Okay, great. One of the doctors is asking that, Dr. Mahanti, again, have you tried liver resections in cirrhotics?
Yes, well, for sure. I think this is exactly the same. So it means that you need time. Cirrhotic parenchyma is sometimes very difficult or very hard, and sometimes very soft. But actually, it's not very easy to predict this. So I think that the best advice is to start with limited resection and to control the hepatic pedicle. So put your bladder tube behind and do not hesitate to make some 15 minutes of clamping and stop for 5 minutes. So like by open actually, but you need to use all these tips and tricks to increase the pneumoperitoneum to 14. Sometimes with 14, it decreases some oozing, and to take time to coagulate everything, to follow the vein, just to avoid injure the large vein, because this is the nightmare is when you injure a large vein. But if you are far from this large vein, if you take your time and you control the pedicule, you can do cirrhotic liver, no problem.
Okay. One of the doctors asking, like, is there any difference in the post-operative transaminitis, like the rise of SGOT and SGPT levels as compared to open surgery and laparoscopy?
It's a very, very interesting point. So actually, there is a tendency toward a lower increase of transaminase. So it means that actually the inflammation induced by surgery is more limited. But actually, for right hepatectomy, we compare liver enzyme test after right hepatectomy by lap and by open, it depends more of the vascular clamping rather than by the surgical approach.
Okay, fair enough. What cases in your number of cases, what you have done in your series, you had to convert open?
No, it's good. So actually, we perform more than 1,200 liver resection by lap. So I think we have a huge experience. In my experience, I have about 400. So because people come in our institution only for that, and actually the rate of conversion decrease over time. So it means that today is about 2%, but actually you just need to, I think the take-home message is it is not a failure to convert. Mm-hmm. If you convert in a good situation, if you convert because this is a major bleeding and you convert in emergency with a large hole in IVC, this is a nightmare. But if you open a large vein and you put a vascular clamp or grasp on the vein and or goes inside, and you close and you convert, this is not a nightmare, and this is not a loss of chance for the patient. So it means that you can start doing the beginning, and when it's difficult, you make a conversion. It's not a failure. So do not preclude laparoscopic approach, because I think it's a good way to start step by step.
Yeah. So David, I have one question in my mind at this stage. Like you have described the position of the patient in something like a semi-prone or a lateral position.
Yes.
Do you use these positions for all liver resections, or you're specific for the site of the resection in which segment you're going to?
Actually, if you are planning to do a segment 7 resection or very high segment 8, we totally mobilize the patient, and not in prone, but in a semi-prone like that, with the right arm above his head, actually. But for segment 6, when you mobilize everything and twist the lever, it's not necessary to install the patient like that. So actually, there is only patient with a I segment 6 or segment 7 or I segment 8. That's all.
What about segment 2 and 3 on the left side? You do supine?
Never. No, never.
Okay, so just go ahead with the supine position.
That's all.
Okay. You have any experience in saying that as a beginners, like what will be the number of cases, especially maybe the simpler liver resections, you can say after these many number of resections, you are good enough to try major resections? Yes,
it's a good question. Actually, this answer change over time. So it means that for the beginners, so for the pioneer like Salvador in a liver technique, or Professor Gaillet in the beginning, I think I think after 30, it's enough. But actually, because we are more experts, in my experience, I'm a young surgeon. I'm okay. I perform a lot, but I think after 15 or 20 complete purely laparoscopic liver resection, I think you can move to the left hepatectomy, or to segment 5 or to segment 6, because actually, if you don't fear to dissect the vein, I think you can follow a medial hepatic vein. So I think that yes, 20 or 15, it's enough.
Okay, fair enough. Anything specifically you do in laparoscopic surgeries to reduce the central venous pressure, other than giving less fluid and increasing the pneumoperitoneum?
No, that's all. Actually, the only things when I arrive in the OR, I discuss with an anesthesiologist, even if it's a new one, anesthesiologist of cardiac surgery, so he does not know anything about liver. So I just explain that don't fill in the patient. You keep it dry, and if I need to, if there is some bleeding, I will explain. You need to use some noradrenaline, so just to keep a cardiac pressure stable over time. So you need to baby noradrenaline, but I think no fluid injection, because the problem is sometimes you're discussing with him and you see just over the field that there is 2, 3 a bottle of serum, and the anesthesiologist is explaining that no, I don't feel in fluid. Say, okay, what? Why do you write number 3 on the serum? So it means that there is always already two. So no, you need to be very cautious about injection of the anesthesiologist. And sometimes when there is a major bleeding, we ask the anesthesiologist to stop for 1 minute or for a few seconds the airway pressure.
Okay.
When there is a major bleeding, he stops the bleeding instantaneously. The problem is the anesthesiologist refuse to do it more than 2 minutes. But actually, it can be a good tip.
Yeah. There's a question by Mrs. Gayani, and she's asking, like, in colorectal metastasis, have you done a concomitant liver resection along with a colorectal resection sometime?
Yes, we can do actually there is different things. So I think from a technical point of view, it's not very difficult, but I can give the advice to start with the liver, because during the colorectal surgery, anesthesiologists inject fluids. So this is the same problem. So you start after 3 hours or 2 hours when the colorectal surgeon is very, very fast. And actually, you need to start liver with some large vein and it bleeds. Second point is because it bleeds, you make some vascular clamping. And there is some edema about the colorectal anastomosis. So I think it's not a good way to start with a colorectal procedure. So it's if you need to do a combined approach, start by the liver. Second point is, actually in my experience, not only in my experience, but when I discuss with a friend of mine, actually there is some specific complication when we combine these two procedures. It means that I don't have many bile leakage, but when you do a left colectomy and atypical resection on segment 2, the only complication I'd observed with this kind of limited resection is only when there is a not very clean situation, when you need to open the colon and so on. So actually, yes, you can do, but keep in mind that the incidence of postoperative complication will not decrease.
Okay, I think I'll just take up the last one. I think just quite ahead of the time. Is there any specific step you take to take care of the bile leakage? Like, do you do some sort of intraoperative cholangiograms?
So it's exactly the same that by open. So actually, if you have a doubt, you can inject through the cystic duct, like for a cholecystectomy, you can inject some propofol, some very fat liquid. But I think it's a better things. But actually, if you use ICG in the next future, ICG is a good thing, because after injection of ICG in the blood, after 15 minutes, or when you start finishing and closing the patient and removing the specimen, I think that the bile ducts are green on the camera, and you can see some bile leakage. So it can be a tip. But actually, you need to use exactly the same by open. So it means that some propofol, you just need to steal the propofol from the anesthesiologist.
And you said some time back that you inject ICG around 2 days prior to the surgery.
Yes. So it's interesting. So if you want to detect lesions, if you want to see better lesions, you inject 2 days before, 1 day before, you inject ACG. It's 1.25 milligram kilograms. And actually, with a camera, all the liver eliminates the ICG, and only fibrotic tissues such as HCC or colorectal liver metastasis keep the ICG. So you see a green ball. It's very, very, very surprising and very interesting. And if you want to see the demarcation, so it's not necessary to inject the day before, but you make a vascular clamping. So you clamp the left pedicule, for example, because you want to do a left hepatectomy. You clamp the left pedicule and you inject intraoperatively ACG, and everything will be green except the clamped liver. So it means that you see very well where to cut. You follow the green line.
Okay, great. I think I would have again to pass on some questions to you on maybe your emails. And there's one interesting question, one of, I think, an impressed audience from, he's asking, is there any fellowships available with you to learn laparoscopic surgery.
Yes, sure, sure. Do not hesitate to send me some email. I will give you my email. And of course, you can come and stay 1 day, 2 weeks, 1 month, or 6 months with pleasure. And I will explain how to do.
And I think same thing goes for Dr. Salvador. I think Dr. Manu is very much interested. He is saying that is there any sort of training module or any fellowship in Spain where we can come and they can spend some time with you?
Yeah, they can come as a server to my center.
Okay.
No problem.
But after the COVID pandemic.
After the pandemic, of course.
Yeah, that's something. I think definitely a fantastic session, Dr. Salvador, Dr. David. Thanks a lot. I think we have few doubts still left, and I think I'll pass on to the technical team, and they will, I think, discuss with you guys also. Very impressive lectures, both Dr. Salvador and Dr. David, and something I think will take forward and take home message will be that laparoscopic hernias are definitely changing, and there is so many things which are coming up. Lira is one thing which is definitely uprising and surprising that we can do these things comfortably. And same thing goes for the liver resection. I think a lot of listeners will be agreeing that they might put their hands in liver resections after the sort of announcement by David. Thank you very much again, and I think definitely we'll keep in touch with you, Dr. Salvador, Dr. David, and fantastic lecture, fantastic videos. Keep in touch and stay safe. And over to Amrita.
Thank you so much, sir. It was indeed a pleasure to hear the two dignitaries today. I would now like to invite two of our managers to give a vote of thanks. Firstly, I would like to invite Mr. Rohit Walia, who heads the North and East for Merrill Endosurgery. Over to you, Rohit, sir.
Yeah, thank you, Amrita. And good evening to all. I'm pretty sure that this must be a good evening for all the enthusiastic young surgeons to learn and participate in this webinar and hear these international great surgeons, Dr. Salvador and Dr. David. Sir, thanks a lot for being there with Merrill. And Dr. Gaurav, thank you very much for moderating this session. And it was flawless, fantastic. I'm pretty sure the participants had a great learning, and we would like to continue, as Dr. Gaurav, you said initially, we would like to continue these webinars on different procedures, different topics. So thank you very much. Thank you.
Pleasure was for us.
I would now like to invite Deepak, sir, who heads the international business for Merrill Endosurgery. Over to you, sir. Sir, you are not audible. Deepak, sir? Can you speak? Hello?
Hello.
Yeah, your voice is a little feeble, sir. Can you be a little louder?
Can you hear me now?
Yes, better.
Okay. So I think we had a fantastic, insightful scientific session today, and on both very diverse topics, one on abdominal wall reconstruction and one on hepatobiliary, which is best of two niche topics that we can look at. And what a fantastic speakers we had, Dr. Salvador, whom I knew for quite some years now. And I also agree with Dr. Gaurav, his experience in a short while, that he is not only a craftsman in his hernia surgery and bariatric, but he's also a good human being. And he's been one of the most humble expert surgeons I have come across in international arena, I would say. And he's been also a guide and source of inspiration to us for many of our own collaborations with him. And thanks to Dr. Gaurav for introducing to us Dr. David Fuchs, and who had a fantastic presentation and a very clinically researched paper, which I think has given a lot of insights to the budding surgeons on liver resection and the other procedures on that. Pandemic has put us on a very tight spot, and we are looking at each week and each month as it goes, because sometimes it's a little opening and then it's under a constraint. And hence we are missing the in-person meetings that we used to have with the customers for the last 9 months, which has not been there. And we look forward that next year, with the vaccines news coming in the market now, hopefully next year should be a little easier for us, not only from the personal front, but also on a professional front, to navigate the pandemic in much better way without risking anybody's life and health. And thanks, Dr. Gaurav, for arranging this webinar. Your initiative is really appreciated. And Dr. Salwa, thanks a lot once again. You're always appreciated for your words, and I think you're one of the finest surgeons who are very upfront in giving the communication. The feedbacks have been absolutely modest and upfront, so which I appreciate. And Dr. David Fuchs, we look forward to meet you sometime in Paris once things are settled and things are more easier to travel now to France, and we'll definitely get in touch with you. Thanks a lot once again for entire fantastic evening that we had today. Over to you, Gaurav. Amrita, thank you.
Thank you so much, sir. We also have with us our business head for Merrill Endosurgery, Mr. Krishnan Vishwanathan. Krishnan, sir, would you like to speak a few words?
Hello, everyone. My apologies. Got a bit delayed thanks to the Sunday, but did not miss the good part of the session. I'm happy to see Dr. Gaurav.
Hi,
About 3 odd years ago, we met in a nice wintry day and we did a nice workshop at his place. But unfortunately, with the pandemic, nothing seems to be moving. But also great to see Dr. Salwa. This is probably the second time we are actually interacting, and brilliant as always. And I sort of agree with Deepak. I'm always amazed at his humility, but also the directness that we put forward this point. And I'm so glad to see Dr. David, because I share some bond with France. So my B school is INSEAD, up Fontainebleau and Paris. So yeah, maybe someday, no idea when, but glad. And thanks a lot to the entire Merrill Endosurgery team for putting this together. Look forward for some more such sessions, and glad to see everyone safe. So please stay safe. And yeah, for people beyond India, Christmas is coming and the New Year's is coming. So season greetings to everyone back home, to you guys. Take care. Thank you.